We have some fellow called Dennis Mureithi. Come, be coming, Dennis. Dennis Mureithi is a consultant, obstetrician, gynecologist, and a laparoscopic surgeon with over 13 years of experience in public and private healthcare. Is dedicated to advancing women's healthcare in Kenya, particularly in rural and peri-urban communities. He previously led OBGY departments at level 4 public hospitals in Kiambu County. Here he has established gyne clinics, expanded laparoscopic surgical services, and operationalized various theater units. He's the co-founder and director of medical services at the HEM practice. Specializes in delivering advanced gynecological care with focus on providing affordable and accessible laparoscopy services. Kama hiyo kushona umeona hapa. He leads the Lap on Wheels program, which was introduced laparoscopy to 57 hospitals in Kenya and serves as the lead trainer under Surgery Edge training. He's also a developer of Endobora pelvic trainer, low-cost simulation tool supporting laparoscopic skill development outside the operating theater. Msi practice na wagonjwa, experiment. Uje mnunue kitu. He's a specialist in pelvic pain and MIS. He has undergone advanced laparoscopic and pelvic pain training in Kenya, Italy, Switzerland, Dubai, Europe, and USA. Ensuring global best practice are adapted to African context. His contributions have also gained recognition, earning him the Harith Hassan Physician from an Emerging Economic Award, AAGL USA, Impact Person Award, Global MVT Partner Foundation, and KOGS Surgical Innovation Laparoscopy Award. His dual approach through expanding access to MIS while training healthcare professionals makes him a visionary committed in making MIS the norm, not the exception. So this program is presenting, usually I charge him for CPD points. Wale wanafundishwa na wapea CPD points as KOGS Central.
Thank you, Daktari, for such a kind introduction. Good afternoon, ladies and gentlemen. It's a challenge presenting in the afternoon. I'm fighting postprandial narcolepsy, so nitajaribu to keep you engaged. So the topic I'm presenting today on is measuring laparoscopic suturing performance using a standardized baseline entry and exit training in a hybrid training program in Kenya. So what are we talking about? We're talking about intracorporeal suturing. So, and intracorporeal suturing, like what Dr. was showing us, is quite a demanding skill, and many educators believe that it is harder to learn laparoscopy, so it is easier to learn a musical instrument. It's also easier to learn how to write with your left hand for those who are right-handed, or to write with your right hand for those who are left-handed, because it requires building of new neural pathways. And if you actually think about it, it actually makes sense about why it's such a difficult thing. We don't, at no particular point in our lives do we use mirror images to operate on. And that's what laparoscopy actually demands you to be able to do. So research has shown over and over and over again that skills gained in the pelvic trainer are transferable to the operating theater. So at the HEM practice, we have a 2-month hybrid laparoscopic suturing program. This is in partnership with, like Dr. Kigondu has said, with KOGS Central, with the American Association of Gynecological Laparoscopists, with the University of Pittsburgh Medical Center, and with Mount Kenya University. And we, in this current presentation I'm making, we're talking about how we have evaluated the impact of this program what we are focused on is ipsilateral suturing. Ipsilateral suturing is the most ergonomic way to be able to do any laparoscopy. Suprapubic, contralateral, not too ergonomic, takes a bit of a toll on your system. It's the hardest to be able to learn, so people tend to shy away from it. But that's what we've chosen to focus on. And we are focused on a 2-month hybrid curriculum that consists of 3 in-person sessions and a minimum of 15 hours of home-based recorded video practice that are assessed. So the assessment method we are using, so we do a baseline test when the participant comes to visit. And when we do the baseline test, it allows us to know where the participant is. And then we do a post-training progressively up to the last day. And this involves a recorded 15-minute video, whereby we expect, or we will be assessing needle handling techniques. That's the ABCs of needle handling. We require the participants to do at least 3 bites, to do 2 sliding knots with 4 throws, and to do 1 surgeon's knot, that's a double throw, and 2 single throws. And the videos recorded during that 15-minute period are assessed, and we assess all those steps. But in today's session, we'll only be focused on the knots. This is what I'm talking about. So this is what we expect every trainee to do at the end of the 2-month program, and that's what we are here to assess. We're looking at a cohort of about 20 participants who came in, and in a 2-month period, they were expected to do this in a pelvic trainer. The video has been a little bit accelerated for you to be able to see the moves. This is a surgeon's knot we're starting off with. So 4 throws. And then now the sliding knot. All these steps are assessed. Actually, to do, because this is just a preliminary report, the full report actually assesses every single one of these movements. You can see there is a useless motion of rotating the needle. If you can notice, when the participants are doing the bite, there's a, let me call it quote unquote, a useless exercise. It's called swiveling. That's what we coined it. So that swiveling technique is what allows you to be able to do those posterior wall suturings that Dr. was talking about, to be able to ensure that the participant is proficient. So, and then now the last sliding knot. So every step is assessed. It's not a useless exercise. Later on, when they find themselves in theater, it actually adds up, and you can actually see the impact. Actually, when we look at the data, we'll realize what we are talking about. So first throw, this is the second throw. We align the sutures, and then we slide, and then we lock the suture, and then we lock it again. Okay. So this is what I was talking about. Hopefully you can see. So this is just we picked an individual report for you to be able to understand what is happening here. So this is just one student and how we were able to assess. You can see week 1, when they came in, we were able to assess the ABC, in terms of the total number of bites. We were able to assess ABC accuracy. We assessed the sliding knot, and then we assessed the sliding knot, so the sliding correct knots. So it's not just any sliding knot, it's the correct one. We assessed sliding knot accuracy. So then we did the sliding speed average, and then we did surgeon's knot, that's the total number, and then surgeon's knot, correct knot, because if you don't do a correct knot, it's discarded. And then we did the surgeon's knot accuracy, and then we did the surgeon's average speed. So you can see over a period of 4 weeks, because of the tests were done, when the participants started, they were only able to do one bite. They were not able to do any knots. And this step is identical from day one. Whether you have been taught or not, it acts as a baseline. So when they started off week 1, the pre-tests, they couldn't be able to do. Post-test, at least they were able to try. They did one correct bite, because by that time we had taught them how to do a bite. And then when we did week 2, which is now where we start learning about the knots, they were able to do 2 bites, still struggling with the knots. But at the end of the day, because the pre and the post test are done in the same day, at the end of the day, our participant was able to make at least one sliding knot. In as much as it was not correct, they were still able to do. We did week 3, and week 3 now you can see there is progression. They were able to do, now we've moved from having to worry about them being able to do a bite, and we've come to now they can do a sliding knot. And actually the sliding knot, they can be able to do it correctly at least 50% of the time. They were still struggling with the surgeon's knot. Week 3 is where we teach them about the sliding knot. And when we look at the final test, which is now the culmination, the participants were able to achieve at least a mastery of 100%. You can see even the sliding, the speed, the average speed of being able to make that knot progressively reduced, meaning that the participant was able to do all those actions within that period of 15 minutes. So the results, this is what we're talking about. Of the 20 participants, there was a significant improvement in the suturing performance. The mean score increased from 0.8% to 80%, a p-value of less than 0.01, with a mean improvement of 80.1%. So you can see from our statistics, 85% of the participants had 67%, they were able to do, to score at least 67%. 60 had a higher mastery score of 83%, and 45% of the participants were able to achieve full mastery at 100%. So this is a table being able to look at the scores that we're talking about, the mean score, the pre-test, the post-test, the median score. So we talked about the competency, so this is a table we've already looked at. And then as a conclusion, what we can say is that all participants demonstrate significant improvements in intracorporeal suturing proficiency post-curriculum. Post-training assessments revealed reduction on completion time, enhanced knot security, superior instrument handling, and greater procedural consistency compared to baseline. Furthermore, higher cumulative practice hours correlated with greater technical improvement. What we realized is that those participants who were able to do all the exercises we required them to be able to do had very good technical mastery, and they were able to do the skills that we asked them to be able to do properly. Maybe if I can give just a comment towards the end. Why we are insisting on laparoscopic suturing is one, it's a core tenet of surgery. You can't do surgery without doing reapproximation. And if you don't learn how to reapproximate, we've got so many devices that can actually be able to help you to reapproximate. Not to say that there's anything wrong with those devices, but in the environments we practice in, our patients can't afford those devices. So either we abandon the technique altogether, or we take the time to be able to master this. And I think what we've been able to show is that these skills are not far-fetched. They can be learned. All that they need is the commitment of the time. And that's what we've been able to see, is that when the students commit the time, they are able to pick up these skills that are extremely difficult, quote unquote, to be able to master. So like I said, this is a preliminary test, part of the study. We hope to be able to do a correlation between what we've been able to achieve in the lab versus what we are being able to see in theater, because we're able to follow them in theater, and we're able to do an assessment of the students while they are in theater. Our argument is, and maybe I would be curious to hear what everyone else's opinion about it is, the people we are training are already surgeons. The 10 steps of a hysterectomy don't change whether you're doing it open or laparoscopic. It's still the 10 steps. What changes is the technique of the approach. So basically, it's you're a proficient driver using a manual car. We want to move you to an automatic car, or vice versa. That's all we are doing. But you're already proficient drivers. So that transition should not be hard. That's the argument we are making. But again, I want to hear what everyone else's opinion is. Thank you.